You are a resident preparing for the FRCS Plastic Surgery Board exams. You, you don't have time for fluff, and you really don't have time for vague overviews. You need to lock down your statistics and diagnostic analysis fundamentals because the examiners will absolutely test your retention on this. Welcome to a highly focused, high-yield deep dive.
Right, because when you're sitting in that exam hall, you just cannot afford to hesitate on these core statistical frameworks.
Exactly. Firstly, head to medsynclimited.com and get the FRCS Plastic Surgery Anki deck with over 7,000 questions arranged by topic to turn revision into active recall. Based on the textbook Keynotes in Plastic Surgery, it is the go-to companion exam question guide.
Yeah, it's definitely an essential tool for this kind of rigorous prep.
Okay, so let's unpack our mission for this deep dive. We are running an active recall session. We're going to establish the hard rules for data distribution, and then we're going to build out the structural logic of the two-way table for screening tests.
Sounds good. And rote memorization just isn't enough here, right?
No, definitely not. I'll be prompting you with questions, and we expect you, the resident listening, to formulate the answer in your head before the explanation drops.
Because we need to break down the what and, crucially, the why of each test and formula. You have to connect the abstract math to the actual clinical decisions you make on the ward, so you understand the underlying logic, rather than just reciting a test book.
Absolutely. Let's get straight into the foundation: data distribution and choosing the right test. Before we can analyze a new diagnostic tool or, evaluate a clinical paper on flap survival, we have to know how to categorize the data sitting in front of us.
Right. The shape of the data dictates everything else.
So here's your first active recall prompt. What is the fundamental rule that dictates when we use a parametric test versus a non-parametric test? Take a second to mentally define the difference.
Well, the entire decision really hinges on the distribution of your data. Parametric tests are used specifically to compare samples of normally distributed data.
Which is your classic symmetrical bell curve, right?
Yeah, exactly. Your classic bell curve. If your data fits that predictable normal distribution, you are operating in the parametric realm.
Okay, and non-parametric tests?
Non-parametric tests, conversely, are used to compare samples that are not normally distributed. If your data is heavily skewed by massive outliers.
Say a few patients who had wildly prolonged hospital stays that just drag the average out of shape.
Yes, precisely. You cannot use a bell curve model for that data. You must use non-parametric tests.
So if I'm looking at an exam prompt, the first thing I'm hunting for is a clue about the data shape. If it says normally distributed, I'm in one bucket. If it says skewed or small sample size, I'm in the other.
Exactly. You always look for those keywords first.
Let's drill the parametric tests first for your perfect bell curve data. What are the 3 specific examples of parametric tests that examiners expect you to instantly recognize?
For normally distributed parametric data, the 3 major tests are, first, the student's t-test, which you'll usually just see as the t-test.
Okay, t-test.
Second, analysis of variance, which, goes by the acronym ANOVA. And third, the chi-squared test.
All right, t-test, ANOVA, and chi-squared. But let's push beyond just a list, because the FRCS won't just ask you to name them. They'll give you a clinical scenario.
Oh, absolutely. They want to see if you can apply them.
Right. So how do we actually choose between those 3? If I'm comparing the healing time of a standard split-thickness skin graft versus a new synthetic dermal substitute, and the data is perfectly normal, which one am I using?
In that scenario, you are comparing exactly 2 distinct groups. For 2 groups of normally distributed continuous data, you use the student's t-test.
Okay, but let's say you decide to add a 3rd group to your study, maybe a different type of biologic dressing.
Right. So now you're comparing 3 distinct groups. A t-test just can't handle that mathematically.
I see.
When you need to compare the means of 3 or more groups, you graduate to the analysis of variance, or ANOVA.
That makes perfect sense. A t-test is a head-to-head matchup. ANOVA is basically a t-test that went to a party with 3 or more groups. What about the chi-squared test?
Well, chi-squared is distinct because it deals with categorical data rather than continuous measurements like healing time or wound surface area.
Categorical meaning putting things into distinct bins, like yes or no.
Exactly. For example, you're looking at 2 different surgical closure techniques, and you want to compare the rate of surgical site infections. Your outcomes are strictly infection or no infection. Because you are comparing frequencies of categories, you use the chi-squared test.
That is a massive distinction to keep in mind. Continuous data gets the t-test or ANOVA. Categorical yes or no data gets chi-squared.
Right. It's a completely different structural approach.
All right, let's flip the script. You're reading a paper on nerve regeneration rates, and the data is heavily skewed. It is not a clean bell curve.
So you need a non-parametric test.
Right. What are the 4 examples of non-parametric tests you need to recall for the board? Think about it for a second.
When dealing with data that is not normally distributed, you have 4 key tests to pull from. First is the Mann-Whitney-U test.
Okay, Matt Whitney, you.
Second is the Wilcoxon-signed rank test. Third is the Kruskal-Wallis test. And fourth is the Friedman test.
So Mann Whitney U, Wilcoxon signed rank, Kruskal-Wallis, and Friedman. Let's map these to the clinical logic we just used.
Good idea. So if my data is skewed and I'm comparing 2 independent groups,
Like the standard graft versus the synthetic graft, but the healing times are all over the place with wild outliers. Which of those 4 am I reaching for?
you would use the Mann-Whitney-U test. You can think of the Mann-Whitney-U as the non-parametric equivalent of the independent t-test. It allows you to compare 2 groups when the data is just too messy for a t-test.
What if I have 3 or more groups of skewed data? What's the non-parametric equivalent of our ANOVA?
That would be the Kruskal-Wallis test. If you have 3 different flap techniques and heavily skewed complication rates, Kruskal-Wallis is your tool.
Got it. That leaves Wilcoxon signed rank and the Friedman test. Where do they fit in?
The Wilcoxon-Sign rank test is crucial when you are dealing with paired data. Think of a before and after scenario on the exact same patient.
Like measuring a patient's grip strength before a tendon repair and then measuring that same patient's grip strength 6 months after.
Exactly. The data points are linked to the same individual. If that paired data is skewed, you use Wilcoxon. The Friedman test is essentially the same concept, but for 3 or more paired measurements.
Like grip strength before surgery at 3 months and at 6 months.
Precisely. That is exactly how you need to store this in your brain for active recall. Don't just memorize a list of names, pair them up.
Right. T-test pairs with Mann-Whitney. ANOVA pairs with Kruskal-Wallis. Getting these mixed up is just an unforced error on an exam.
And the board examiners will test this categorization rigorously because if you apply a parametric ANOVA to non-normally distributed data, your entire clinical conclusion is mathematically invalid.
Precisely. Categorizing the data dictates the architecture of the math. Once you understand the rules of the data, you can start evaluating the actual diagnostic tools we use.
Which brings us to the core of evaluating clinical tools, analyzing screening tests.
Exactly. We've figured out how to look at study data. Now we need to look at the tests we use on patients every single day.
Right.
To analyze these screening tests properly, we rely on concepts like sensitivity, specificity, and predictive value. So, listener, here's the question. What is the single best structural way to define and organize these concepts so you don't get paralyzed by the word problems on exam day?
The absolute most reliable method is to construct a 2-way table. You create a grid that forces you to compare 2 distinct intersecting realities.
Which are?
The result of the screening test, which is either positive or negative, mapped against the true state of the patient, which is either disease present or disease absent.
Let's map out that grid right now so you can visualize it instantly. This has to become muscle memory. Imagine a box divided into 4 equal quadrants. Top left, top right, bottom left, bottom right.
And we're labeling these quadrants A, B, C, and D.
Let's establish the axes. Across the top, our columns represent the actual ultimate truth of the patient. The left column is disease present. The right column is disease absent.
And down the side, our rows represent what the diagnostic test says. The top row is test result positive. The bottom row is test result negative.
Let's make this tangible with the plastic surgery scenario. Let's say we are using high-resolution ultrasound to screen for silent silicone breast implant ruptures. The disease is a ruptured implant. The test is the ultrasound.
Okay, so left column, rupture present, right column, rupture absent, top row, ultrasound positive, bottom row, ultrasound negative. Let's populate the quadrants.
Do you have the grid in your head? What exactly does quadrant A, the top left box, represent?
Well, quadrant A sits at the intersection of disease present and test result positive. So A represents the scenario where the patient truly has a ruptured implant and the ultrasound correctly identified the rupture.
Perfect. That is your true positive. It's the ideal scenario for catching a problem. Now, moving across the top row to the top right box, what is quadrant B? Think carefully about the intersection.
Quadrant B sits at the intersection of disease absent and test result positive. So B is when the patient has a perfectly intact implant, but the ultrasound incorrectly flags a rupture, perhaps due to an artifact or fold in the shell.
This is explicitly your false positive. Let's pause on quadrant B, the false positive, because it has real clinical weight. The rupture is absent, but the test screams positive.
Right. If you act blindly on quadrant B, you are taking a patient to the operating theater for an unnecessary explantation surgery. It's a huge deal.
Now let's drop down to the bottom row,
Hmm.
bottom left box. What is quadrant C?
Quadrant C sits at the intersection of disease present and test result negative. So C is when the patient truly has a ruptured implant leaking silicone, but the ultrasound completely misses it and reads as normal.
This is your false negative. Quadrant C is the nightmare scenario. Whether it's missing an implant rupture or worse, a false negative on a screening biopsy for melanoma. The disease is present, but the test gave you false reassurance.
It's the worst outcome. Finally, moving to the bottom right box, what is quadrant D?
That's at the intersection of disease absent and test result negative.
Right, yeah, exactly. D represents the scenario where the patient have a healthy, intact implant, and the ultrasound correctly confirms there is no rupture. This is your true negative.
Excellent. A is the true positive, B is the false positive, C is the false negative, D is the true negative. If you cannot draw this A, B, C, D table from memory, the moment a statistics question pops up on your screen, you are operating at a massive disadvantage.
Because the examiner's left to give you a dense paragraph full of percentages and raw patient numbers to confuse you.
Yes. Do not try to hold the math in your head. Draw the box. Plug the numbers into A, B, C, and D. Because once the numbers are in the right boxes, the advanced formulas just become basic arithmetic.
That spatial mapping really is everything. Once the grid is built, we can calculate the actual performance metrics of the screening test itself. We need to know how good this ultrasound actually is at its job.
And that requires calculating sensitivity and specificity. Let's test your active recall on this. How do we define sensitivity, and what is the exact formula using our two-way table? Formulate your answer.
Sensitivity measures how often the test is positive in disease. The exact formula using our grid is A divided by the sum of A plus C.
I really want to break down the mechanics of that formula so we aren't just reciting letters. A divided by A plus C. Mathematically, A plus C makes up the entire left column of our table.
Correct. That entire column is labeled disease present.
So does this mean sensitivity completely ignores healthy people?
Yes, entirely. Sensitivity isolates the disease-present individuals. It only looks down the left column.
Okay, so it asks a very specific question. Out of every single person who truly has a ruptured implant, which is A plus C, how many did the ultrasound correctly manage to flag as positive, which is A?
Exactly. That is why it is a measure of the test's ability to detect disease.
That vertical logic is key. Sensitivity looks straight down the left column. If a test has high sensitivity, quadrant C, our nightmare false negative scenario, must be very small.
Precisely. Okay, let's look at the other side of the coin.
Right. How do we define specificity, and what is its exact formula?
Specificity measures how often the test is negative in health. Using our table, the formula is D divided by the sum of B plus D.
Let's apply that same mechanical logic. B plus D makes up the entire right column of our table, which is labeled disease absent. So specificity isolates the healthy individuals.
Yeah, out of everyone who actually has an intact implant, which is B plus D, how many did the ultrasound correctly clear as negative, which is D?
If we look at the bigger picture here, notice that both sensitivity and specificity operate vertically on your table. They calculate fractions of the columns.
They're defining the inherent properties of the ultrasound machine itself under ideal known conditions. They basically tell you, if I know this patient is sick, how likely is the test to show it?
Right, but here is where clinical reality hits. When you are sitting in the consultation room, you don't know the ultimate truth of the patient's condition. If you knew they had a rupture, you wouldn't be ordering the ultrasound.
Exactly. You are holding a piece of paper with a positive test result, and the patient is looking at you asking, "Doctor, what are the actual chances I have a rupture?"
And sensitivity doesn't answer that question at all.
No, it doesn't. That question requires predictive values. Sensitivity and specificity tell us about the test's inherent lab performance. Predictive values tell us the real-world likelihood of the disease for the specific patient holding a specific result.
This is a massive distinction for the boards. Let's test your recall. What is the definition of positive predictive value, and how is it calculated using our table?
Positive predictive value is the likelihood of disease if the test is positive. The formula is A divided by the sum of A plus B.
Notice the shift we just made. We are no longer looking down a column. A plus B is the entire top row of our table.
Right. It is every single person who got a positive ultrasound result. So out of everyone who had a positive scan, how many actually have a real rupture, which is A.
This is what matters to the patient.
Mm.
They care about their specific positive result, which absolutely includes the risk of being a false positive.
And that false positive risk is quadrant B, sitting right there in the denominator of the positive predictive value formula.
Let's finish the grid. What is the definition of negative predictive value, and what is the formula?
Negative predictive value is the likelihood of health if the test is negative. The formula is D divided by the sum of C plus D.
C plus D. That is our entire bottom row, everyone who got a negative test result.
So out of all those negative scans, how many implants are truly intact, which is D? The patient wants to know, if the scan says I'm fine, how confident can I be? That is your negative predictive value.
Before we wrap up, I want to explicitly spell out the memorization hack we just built. It's brilliant. Listen closely to the structural difference. Sensitivity and specificity focus on the presence or absence of the disease itself.
They operate vertically. They look down the columns of our table.
Yes, their denominators are A plus C and B plus D. Predictive values, however, focus on the test results. They operate horizontally. They look across the rows of our table.
Right. Their denominators are A plus B for positive tests and C plus D for negative tests. Vertical for the test's inherent performance. Horizontal for the patient's real-world likelihood.
If you can just remember vertical versus horizontal, you can instantly derive all four of those complex formulas from your simple A, B, C, D box. You don't have to blindly memorize a string of letters.
You are applying a rigorous logical system, much like choosing your data distribution tests earlier.
Exactly. The statistics of diagnosis might seem abstract compared to the tangible reality of a reconstructive flap, but there is an underlying architecture. Build the table, respect the columns and rows, and the math becomes just as precise as your scalpel.
We covered a lot of ground quickly here.
We did. We are wrapping up this active recall session here. We established the rules for parametric versus non-parametric data, pairing t-tests with Mann-Whitney U, and ANOVA with Kruskal-Wallis.
We constructed the ABCD two-way screening table, too.
And we calculated sensitivity and specificity vertically and predictive values horizontally. These concepts are the absolute bedrock of your board exams.
They really are foundational.
As you continue your revision today, I want to leave you with a provocative thought. Think about how you would map a completely novel experimental screening test onto an ABCD table under the extreme pressure of the exam hall. If they throw a massive block of text at you about a new biomarker for squamous cell carcinoma, can you instantly, reflexively visualize which quadrant represents your false negative nightmare versus your false positive?
That's a great exercise.
Leave a comment or question below regarding any of the specific statistical tests or formulas we actively recalled today. Keep drilling, trust the frameworks, and maintain that clinical precision. Keep diving deep.